So I'm Stephanie Ogden. I'm a dermatology consultant at the Northern Care Alliance and the Skin Cancer Pathway Board lead. So for our first talk, I'm really delighted to introduce Dr. Jess Grundy, who is a GP colleague and also an expert in medical education at the University of Manchester. She's going to do something a bit different for us today and talk to us about how we make our decisions, and hopefully that will feed into our later talks when we're looking at some skin lesions and deciding what we think they are and what we're going to do about them. Jess.
Thank you for the warm welcome, Stephanie, and hello to everybody. I'm a GP, and as Stephanie mentioned, I work at the medical school, where I wouldn't say an expert, but we work very closely on teaching our medical students about making decisions and about how to avoid making mistakes. And some of that is very relevant to dermatology. So I'm really thankful to my colleague at the medical school, Professor Minnie Singh, who's a consultant dermatologist who works at the NCA with Stephanie, and the rest of the clinical reasoning working group for helping me with these slides, which I hope are going to make you think in a different way and get the most out of the rest of the afternoon. Okay, so without further ado, so the theory of clinical reasoning. So what we're going to do in the next half hour is we're going to briefly talk about what I mean by the term clinical reasoning. Some of you may have come across it before, it might be new to others. Hopefully we're all going to be aware of it by the end. We're going to think about why that matters in particular when we're trying to recognise skin lesions, and hopefully you're going to take something forward that you're going to do differently as a result of this little half-hour interlude. Okay, so this is what we're going to do, being aware of that latest thinking and considering how it's going to impact you. So, what is clinical reasoning? What do I mean by that term? And why am I bothered about it? Well, clinical reasoning is the process by which all of us as clinicians, and I know there's lots of different specialty and different people here with different experience, but all of us as clinicians collect information from our patients to understand what's going on. We plan and implement appropriate action plans, and then we reflect on that and learn for it for next time. And that's what we're doing every day with our patients. And essentially what this means is that this is clinical reasoning is all of that means it's how we make our decisions. And it's how we make our decisions which has an outcome, a good or a bad outcome for our patients. So decision making is critical. So, why does this matter, and why have I got a picture of the toilets? Well, diagnostic error is one of the most problematic results when we don't make good decisions for our patients, when we make an inaccurate diagnosis. And it's one of the most serious things that can cause the most harm. And sometimes that decision-making is due to problems in the way that we've thought about the problem or assessed the problem. And those things can be conscious or subconscious. They can have biases that affect our thinking. But there can also be things outside of our immediate context, outside of us, that can affect how we think. And a few years ago, Professor Cross-Kerry published a paper which has been really seminal in this area, which outlined that if we're aware of the way we're thinking and try and be aware of the things that might be pushing us off track, we can maybe try and mitigate that to make better decisions. And this is exemplified by the fact that there was a study done that won the Ig Nobel Prize, not a real Nobel Prize, it's like a joke one, but it showed that if you need the toilet, it can affect your decision-making process the same as the drink drive limit in Scotland. So I'm sure many of us wouldn't go to work, in fact, all of us wouldn't go to work over the drink drive limit, but how many of us have needed the toilet when we've been trying to rush through a surgery? So bear that in mind. If that's one thing you take from this, is looking after ourselves and going to the toilet. But the reason that this matters so much is that the impact on patients from our decisions. And this is another paper, at the medical school we love our papers, but this is another paper that demonstrates how this is important. And it can be thought of as sort of opportunities to do good for our patients and make the right diagnoses and the right plans. And if we look at that diagram in the green and the A, some of those missed opportunities to make the right diagnosis could potentially have been altered if we were aware of some of the other factors that are affecting our decisions. There's always going to be things that we can't change, but there's some, if we have a look at that B part, so A is when there's no harm to the patient, but the B part is when actually something has happened to the patient that's resulted in harm. And all of that in green may be improved if we're aware of how we're making decisions, which is how I'm going to challenge you to think about skin lesions today. So, yes, knowledge is important. So you're going to get some knowledge today. Everything relies on knowledge, but we've known for a long time that for clinicians, knowledge alone is not enough. That's a bit of a worry, isn't it? Maybe not. We're going to give you some tools. So knowledge alone is not enough, but it's our ability to make good decisions, which is the critical part of using that knowledge. And that's what we're going to explore. So I don't know if any of you have seen this book. Yeah, this guy got an actual Nobel Prize about this, this theory, thinking fast and slow. He describes work built on Stanovich and West's work, who were psychologists, to describe two ways of thinking, particularly around decision-making. This is important to think about. So system one is fast. It's almost outside of our awareness. System two requires deliberate thought and feels hard. It feels hard work and it's slower. So why is this important for us? Well, can anyone shout out the answer to that question? Yeah, brilliant. Instantaneous. You knew it. I didn't see anyone reaching for a calculator or a pen and paper. You've seen that before. You know it. Pattern recognition, system one, type one thinking. Similarly, if I were to say to you, what's the likely diagnosis? Yeah, MI, ACS, something like that, straight away. None of you have had to think really hard, retrieve some pathophysiology. You know that because you've seen it before. That's pattern recognition in, for us, type 1 thinking. Okay? No? Okay. You haven't seen that before. I'm not expecting any of you to know it. It's a type 2 problem. It would take you something to help you. It would take some time. It's slower. It's type 2, system 2 thinking. And we'd often associate this type of thinking in clinical practice if that landed on our desks and we had to work through a really complex patient. So I've got a question for you. What type of thinking do you think is mainly for us in the community skin lesion recognition?
We think it's one, but can be two.
So really good answer. We think it's one, but it might be two. Yeah, any other thoughts on that? I think you've hit the nail on the head. That actually, a lot of our teaching and a lot of our revision for dermatology goes through lots of pictures and images. And we think that we should be able, having seen one, to recognise another one immediately, type 1. But actually what I'm going to suggest to you today is that we should be employing more type 2 thinking with our lesion recognition. Because actually, it's more than a spot diagnosis a lot of the time. And that's okay. We don't have to do spot diagnosis. It's okay, and it might be safer to do a bit of type 2. So just going to put that seed in your head. It's just to mention that, of course, we don't always operate in just type 1 or just type 2. in reality, we're toggling between type 1 and type 2, even with the same patient. So it's not that you have to be in 1 or 2 all of the times, just to make that point. And the time that we spend in each system, each type of thinking will vary for each of us during the day and with experience. So our knowledge is in, if we think about now how our knowledge is stored and retrieved in these systems, all of us, for every condition, produce our differential diagnoses through multiple sources of information, and that is also true for skin lesions. So we think about the history, we think about the time course, the red flags, the epidemiological features for that patient, the diagnosis, has it, what's happened since you've tried a treatment. All of that feeds into our differential diagnosis, our hypotheses, our ideas, in order to make the right diagnosis and the right plan for a patient. So what influences our accuracy with that diagnosis? Well, again, I'm going to have you thinking of this in a different way, because it may be that you think, well, maybe just looking at lots of pictures. But actually, there's more to it than that. And if we think about our thinking, it can help us. So the dual process theory is another theory about thinking, which is it's not for clinicians, but it's very applicable to clinicians. It's a universal model, and it describes decision-making and reasoning. It explains how thinking goes from type 2 to type 1, how it becomes automatic, and it also lets us see and be aware of the things that can also affect our decision-making. So, here it is. A patient presents. We either recognise that thing, that lesion, straight off, and we're into type 1, we know what we're doing. But more likely, in the community for us, we're not going to immediately spot diagnose that lesion. We need a bit more information. We need to apply our knowledge and rationalise and make some decisions on that patient. Now, of course, if we keep seeing that same lesion over lots and lots and lots of times in different presentations and different histories to go with it, epidemiological courses, all these other things, then of course it can go into type 1. And this isn't just out of our control. We have control over this. It is in our gift to control it. But sometimes we're not in complete rational control, and other things can affect us. So all the time we're calibrating, and things can positively calibrate us to make a good decision or bump us off course. We can also, at any point, override it. And the way I like to think about this diagram is that all this thinking is going on, but the white is the soup of what's surrounding us. And the soup around us is determining which system we're toggling more in between. So in terms of that, the soup of factors that can affect our thinking, does anyone have any ideas what might affect this system? What's surrounding us that affects our thinking? Phone calls, emails, yes. Needing the toilet, yes. Interruptions, yeah, absolutely. Anything else? Hungry, yeah. Your mood, yeah, absolutely, absolutely. So all of these things can affect how we think, and often that acronym is called HALT. So this is a commonly recognised things that can affect that decision-making process. So hungry, angry, late, and tired is the recognised acronym. I like to think of it as annoyed, because I'm not very often angry in work, but I might feel a bit annoyed if I've had to load the computer twice already. If I'm late, so again, rather than late, I think of rushing. If I'm rushing, am I more likely to just say, that's okay, without properly making an assessment? And if you're tired, that can affect how we think. And all of these things, as well as the human factors around us, the teams, the systems, the referral process, all of the things, the computer, I'll say again, all of these things can affect how we make our decisions. And if we're aware of these things, we can hopefully take steps to just check in with ourselves if we realise that they're affecting our decisions. Okay, so we're obviously in the community using more telephones to consult. We are using messages and videos, perhaps a bit less now than during the pandemic, but we are still using these methods to consult. And there's been a lot of benefits with that. I'm going to ask you if that system, if we think of that slide with the thinking processes, is the system of telephone consulting beneficial for skin lesions? I can see a few shakes of the head. Well, let's have a little interaction here. So imagine we're on the phone and we've sorted somebody out safely on the telephone, but at the end they say, I've also got this mole I want checking. Okay, I'm going to ask you all now, what's your first response going to be? And we're going to put up, if you go to menti.com, and my colleagues at the back will see what in the room we're going to do. Your first response, gut instinct, what are you going to do? Someone says on the phone, I've got a mole, doc. If you go to menti.com and then just there's a number at the top of the screen. Yeah, some of you found it. Brilliant. Okay, I think we've probably got everyone's responses, and a few of you have said you're going to share your idea in the room. So I don't know, obviously, who you are, but if you could share your idea in the room, I'd be very grateful. Yeah? Oh, there's a microphone coming, actually.
Sounds very official now. Yeah, I put that because obviously we can, if there is time in that current consultation, you could take a bit more history. Obviously, if it's something that's been there for years, they just want you to cast an eye, because come and see me is okay, but then when is the question? If it's something new, it's rapidly changed size, then, so just to get a bit more idea as to when you would want to bring them in. If you're not too worried, I suppose you could ask for a picture. So it all depends. So you don't have to automatically not deal with it. If you have the time, you can do little bits and then kind of decide. That's what I would do, yeah.
Brilliant, thank you. Thank you for sharing. Anyone else want to say what they would do? No? No one's brave. Okay, could we go back to the slides, please? Thank you. Okay, so we've got roughly half and half with coming in and sending a photo. Okay, so what's the, thinking about now our thinking, what's the risk with sending a photograph, do you think? And I think a lot of us would do that, as we've seen, half of us would. What's the risk with sending a photograph? Yeah. So yeah, so someone's saying you're not really getting much history. You're sort of looking at that picture, trying to do a spot diagnosis. It almost forces you into doing a spot diagnosis. You're not looking at the rest of the skin. Yeah. Oh, the pictures you get. Yeah. They might not be able to send a picture. Yeah. You can't touch it, yeah. So why do we do that? We have all done this, I'm sure. So why do we? Yeah, so someone's saying, just so everyone can hear, it might be a way to triage. So if you see that it looks a bit dodgy or it looks completely fine, it can help you when they might come in to do that assessment. Yeah, or if it's a really rubbish picture, then that's decision made on your behalf, isn't it? What you're going to do, you're going to get that person in. Yeah, absolutely. Why else do we do it? Might reassure the patient, yeah. Yeah.
Keep a record.
And keep a record, yeah, absolutely. So there are lots of reasons why we might do this, and I'm not saying it's wrong. There's lots of good reasons why we might send a picture. But what I'm just suggesting is that there's more to it than the photograph. And sometimes that photo can lead us off going onto a spot diagnosis route, when actually a better decision could be made if we were to take a history, examine that patient, like for other things. Because it's very tempting when you've got the picture to make a diagnosis. It's tempting to miss out the other bit that's required to make the best diagnosis. And one of the other reasons that we may do this and to ask for a photo is about time efficiency and being time efficient, and that's your judgment to do. But one of the things that can happen with that is that's a system pushing us into making that decision rather than that being the right thing for that patient. So this is why we're just trying to look at skin lesions in this context a bit differently, perhaps, to other teaching that you might have had. So I hope you find this interesting. Anyway, so essentially, there's more to making an assessment of a skin lesion than just the snapshot. So the full history is as important as any other condition. We're going to think about generating different hypotheses as we would with other conditions and trying to assess risk like we would with other conditions. And we're going to try today to avoid that feeling that we have to make a snapshot, a spot diagnosis, although there is that temptation. And that quote you've probably all heard as a medical student, but more than most of the diagnosis, even for skin lesions, is through the history. And I just wanted to remind us of that because we can often fall down the trap of thinking it's all on what the lesion looks like. So what I'm hoping that we're going to do for the rest of the afternoon is to apply some analytical decision making to some skin lesions. You're going to see some cases and work through some cases with my colleagues. And what diagnostic accuracy relies on is being aware of all these things I've talked about, but also accumulating lots of different patient histories and examinations and reflecting and debriefing on that ideally. That's the closed loop of the clinical decision making and clinical reasoning. So how you can apply this, I've got some ideas for you. So we're going to be aware of thinking and decision making today as we'll work through some case examples. In your practice, try and be aware of these other factors that can affect your thinking on a day-to-day basis. We didn't mention, my colleague at the back mentioned interruptions, the emails constantly, but, a lot of us have more than one screen. It's a lot. It can be distracting. Human factors, the way that we're working can all affect us. We need to look after ourselves so we're not rushing and late and tired. Not waiting to go for a wee. That's the one thing you've taken, that's all right. So I hope that's been a little snapshot, which is going to introduce the rest of today. Just have us trying to think about skin lesions a little bit differently to perhaps other dermatology events that you've been to. After today, there is more information coming to you about opportunities to embed this in clinical practice with face-to-face teaching. And I'd really recommend that as a follow-up to the classroom-based teaching today. And that's it. I'm just on time, so I've done quite well, I think. I have got a couple of minutes for any questions, and otherwise I'll hand over to do these cases. No questions, great. I'll hand over. Thank you.
A lot of food for thought there. So we're moving on now. John and Kate, two of my colleagues, are going to talk to you about actinic keratoses, making the diagnosis and treatment with some interactive cases along the way where we'll want you all to contribute and have, use some of the skills that you do automatically that Jess has just been talking to us about, and hopefully to try and sort of cement some of these ideas going forwards for your clinical practice. So it is an interactive session, so please do join in, do ask any questions if anything's not clear as we're going along. We're happy to be interrupted. John and Kate.
So thanks, Steph. And as Steph says, I'm a consultant at the Northern Carolines. My name's John Lesion. So I'm just going to talk you through, we have to almost take a step back from what Jess was talking about and think a bit about knowledge first, and then we'll come on to our case studies, and then hopefully we can use that knowledge in a way to think about those decision-making and reasoning. Wrong way, sorry. So those are my disclosures. So we're going to do a bit of a knowledge check first, talk about making the diagnosis in actinic keratosis, treatment options that you might have available to you, think about managing side effects, because I'm sure that's a common thing that you'll get questions about from patients who've had side effects from treatment, and then we'll move on to the interactive case studies with Kate. So I just want everybody to have a little think and maybe try to write down on a scale of 1 to 10, and the same for people who are online, how confident you feel at making the diagnosis of an actinic keratosis, just on a scale of 0 to 10, and just make a note of it. How confident are you to discuss with your patients the treatment options and pros and cons of treating actinic keratoses? So, and just have again, think about the scale. And then how confident are you to recognise and manage treatment-related side effects? So just want you to think about those things and write on paper where you feel at the moment on that scale. And then we want to maybe think about those questions at the end. So if we think about actinic keratoses in general, we're going to try and think about making the diagnosis. So in terms of, I'm taking a sort of step back and sort of from Jess's approach as the type of the first type of thinking, but essentially we're going to talk about what they look like, because actually we'll come on to the reasoning later on. So they tend to look like skin-coloured to reddish-brown scaly macules, papules or plaques, and the key to diagnosis on physical examinations, they often have this gritty or sandpaper-like texture to them, and there may be more than one lesion. They're usually a few millimetres in size, but you can get larger lesions. And you often do, as I say, get multiple lesions on the skin. And you sometimes get lots and lots of actinic keratoses making a confluent area of sun damage. And then there's all these different types of pigmented actinic keratoses and boenoid and lichen planus, and you can worry about all of those things, but you don't necessarily need to, but just recognise that they can look quite different, which was why thinking about history and everything else and putting it into the context of how the patient's presenting is important. So, and there you've got somebody with really lots and lots, that could even be a rash if you didn't think about the history in the background. But this is sun damage on the back of somebody's hand. So, in the BAD guidelines in 2007, it highlighted the low rate of malignant transformation. So about 1 in 1,000 actinic keratoses will turn into a skin cancer. But nonetheless, the majority of squamous cell carcinomas arise for actinic keratoses. In the BAD in 2017 updated their guidance and really highlighted the fact that the prevention of subsequent skin cancers is the reason for treating actinic keratoses. And you obviously need to put them post-appropriate management plan in the context of the patient's concerns and thinking about what they want to do about the lesion as well. which we'll come on to later. So, and patients, they highlighted in the 2017 guidelines of the BAD that in particular patients expressed concerns in respect to the disease itself, side effects of treatment, association with cancer or potential for cancer, and the need to adjust their behaviour. Which is interesting. So, and the other thing to really highlight to people is that a proportion of actinic keratoses, particularly the very early actinic keratoses, do actually resolve on their own, about 25%. So there is always the option of no treatment in the right clinical context. So, really helpfully, the BAD, I don't know if anybody's seen this, but there is a link, there's a website link up there, but basically the BAD have put together certain pathways for certain common conditions that are treated in primary and secondary care, and sort of highlighted what you should do at a primary care level before you think about referring in, or you know, how you might think about approaching a patient who's presenting with whatever condition. And there is one for actinic keratosis, which is very helpful, and I think you should read after the meeting. If a person's got 10 or more actinic keratoses, there's a 10 to 15% risk of them developing a squamous cell carcinoma down the line. And it's estimated that around 19 to 24% of people will, over the age of 60, will have at least one actinic keratosis. So there's a lot of people with a lot of actinic keratoses that potentially might need treating. It's interesting as well that the PCDS and the BAD guidance do highlight the fact that most actinic keratoses can be treated in general practice, and of course we are here to support in secondary care for those patients where there's more challenges, which again we'll touch upon later on. So you might see that when we write letters back from secondary care, we sometimes grade actinic keratoses. So this is sort of mild, moderate to severe, or grade 1, 2, 3. And it's just helpful to think about how you might approach them in terms of management. So grade 1 actinic keratoses tend to be these very flat lesions. They may have a little bit of hyperkeratosis or even look a little bit atrophic, some of these lesions. They're often a bit red. You can see in these photographs that these are occurring in patients who've got quite a lot of sun damage in the background. So you've got fair-skinned individuals, so skin type 1 or 2, if you use the Fitzpatrick grading, and essentially really quite extensive actinic damage in these photographs that we can see. So if we then move on to sort of thinking about the next sort of type, these are ones that are a little bit thicker. So the photograph on the left-hand side of the screen there, you can see there's some more flat sort of scaly change and then a thickened area within that. And again on the nose there, a more thickened area. So these are what we call grade 2 or moderate actinic keratoses. And then you've got a subset of actinic keratoses. They're actually really quite thick. And you know, when you first look at these can look quite alarming. You have to assess them carefully as to what you're going to do about them, essentially. So lots of patients will have not just one actinic keratosis, because of course this person's skin, to get one actinic keratosis, will have had similar amount of sun exposure on the adjacent skin. So actually what can be quite confusing sometimes when you see somebody initially presenting with actinic keratosis, actually they might have quite confluent changes. So here we can see that somebody's got what we call actinic field change. So this is where you've got multiple actinic keratoses occurring on the background of usually a patient with type 1 or 2 skin. So in primary care, I very much would encourage that your treatment should be in the spectrum of treating these early, so what we call grade 1 or mild and moderate actinic keratoses. And you've got lots of treatment options available to you, which we'll come on to. So the more thick actinic keratoses, the ones that have got a real hyperkeratotic feel to them or have grown a cutaneous horn, are much more likely to progress to an invasive squamous cell carcinoma. And or STCs can be more difficult to exclude, and they're more likely to need secondary care-based treatments like curettage and cautery or surgery, etc. So in terms of the photos that you see here, so if you think about the photo on the left, sort of, would you refer that into secondary care? Yeah, I would, you know, it's a cutaneous horn. I think that's totally reasonable. We're probably going to treat it surgically and scrape it off. And what about the one on the image on the other side? Yeah, so we're worried that this is a hyperkeratotic lesion arising on an indurated base. So we're going to be worried about presumably a squamous cell carcinoma. Fantastic, yeah, great. So there are some certain things that you might want to look for in the history when you're thinking about taking your history and thinking a bit laterally about what the diagnosis might be, and this will help your decision making. So squamous cell carcinomas tend to be painful. If you see an actinic keratosis that's particularly large, then you may think, well, could there be an SCC arising within this, or has it been there a very long time, and I'm worried about an SCC arising within it. If you've got a lesion on the nose or on the ears, on the backs of the hands, the scalp, these are all sun-exposed sites. These are more likely to turn into skin cancers, but that's just because they're on sun-exposed sites. But it's just important to think about where the lesion is. If I've got any doubt, do I need to refer this into secondary care? And of course, we'll welcome those referrals when you're concerned. Do you know of any benign lesions or malignant lesions where cutaneous horns? So let's go with benign first, where you might get a cutaneous horns. Anybody know? Say again? Seborrheic keratosis, yeah, sometimes, yeah. Any? Warts, yeah. Keratoacanthoma. Yeah, KA always comes up. I mean, KAs can't usually be diagnosed histologically as to whether they're well-differentiated SCCs or keratoacanthomas. I personally think that KAs are just a form of SCC, and a small proportion of SCCs spontaneously resolve. And often when you analyse them under the microscope, the pathologist can't tell either. So we manage them in the same way. So if you think something is a KA, that is an SCC, and you refer it in to us on a 2-week wait basis. Oh, go ahead.
Just a question on the previous slide.
Yeah, this one.
Sun-exposed areas.
Yep.
I do wonder about the penis.
So, yes, so mostly on sun-exposed areas. However, we mentioned penis because I'm sure if you saw a hyperkeratotic indurated lesion on the penis, you'd think about a skin cancer or squamous cell carcinoma. A proportion of patients with things like lichen sclerosus will be prone to getting SCCs. So it's just, yes, that isn't sun-exposed. In most people, of course. Most people. So benign lesions we mentioned about viral warts. Sometimes lichen planus, you can get hyperkeratotic cutaneous horns arising from it, and that can be quite difficult to distinguish from sun damage sometimes. But then you've got the pre-malignant and malignant conditions, which we've listed there. And I've put keratoacanthoma in because I knew it would come up, because it always does. And then if we're thinking in our history about risk, it's important to think about the patient that's presenting to you. So there will be a proportion of people who are immunosuppressed long-term for whatever health conditions, so people with rheumatoid arthritis or Crohn's disease, etc., that will be at increased risk of getting skin cancers. So it's just important to think, if you've got somebody with something that you think is a skin cancer or possible precancerous lesion and they are immunosuppressed, then those are the types of patients that you do want to be referring to us, because actually, if they're a transplant patient, for example, they should be under the care of a dermatologist long term and they get seen annually, etc. So that's one of the things that might make you think, actually, I really need to refer this patient. If people have had a previous skin cancer, now you've got to bear in mind that there's going to be some judgment over that. You might think, oh, well, they have had a skin cancer, it was 15 years ago, and they're presented with a little tiny scaly thing, which I think is an AK. And you then make a clinical judgment as to whether you feel that you need to refer them or not. But of course, if you're not sure, we're more than happy to see people. And then obviously excessive sun exposure is relevant in your clinical history as to how you're going to assess the patient and what you're going to do with them in terms of your management options down the line. So that's just sort of covering some of the background, and then we're just going to think about treating actinic keratoses. And you've actually got quite a lot of different treatment options. I'm sure you're aware there's different treatments for actinic keratoses. So one of the main things to consider is somebody presenting with a singular lesion, or are they presenting with a few lesions on their right temple, for example? So you've got this sort of, some people need single lesion treatment, some people need field treatment, and somewhere in between there's a mixture, and some people need a bit of both. So you've got to think about your treatment options and choices in the context of what you're presented with. So it's important, of course, to highlight the importance of sun protection to patients. So wearing a broad-brimmed hat, wearing high-factor sunscreen, factor 50 UVA 5-star, in terms to prevent further sun damage. But you're presented with somebody with sun damage at that point in time. And you can, particularly in the milder AKs, particularly if people have only got one or two, give them the option of no treatment. That is something that you can consider. And of course, it's in the guidance. So if we think about those grade 1 or mild actinic keratoses, we're thinking of these flat pink patches, maybe a bit of scale, a little bit roughened to touch. For isolated, for initially, you've got the option of topical treatments such as Efudix or 5-FU. For a single lesion, you may want to use something like Actinic, which is painted onto the lesion, and I'll come on to that later. You've got the option of Imicramod, or Aldara. It's not always available at the moment, so sometimes people are using the other available formulation, but for 5% Imicramod essentially. And then there is the option, of course, of topical diclofenac, which we will come on to later as well in talking about the various options, the potential side effects of those options. So if we think about moderately thick actinic keratoses, we've still got very similar treatment options available to us. So we've still got our Efudix option, we've still got our Imicramod option, and we've still got our Actinic option there. And then there are some nuances about how hard one treatment is to use over another, etc. But you'll see there's some common themes that run through these. How many people, out of interest, have access to cryotherapy? Oh, there's a question.
No, I do.
You do? Okay, put it. Yeah, fine. So, does anybody else have access to cryotherapy? So, yeah, there are a few hands going up, so about 4 hands in the room. So that's a potential option for some lesions. So an isolated lesion, you might want to use cryotherapy if you feel confident to do so. We do sometimes use curettage and cautery in secondary care, certainly to treat thickened actinic keratoses or singular lesions, which patients have not responded perhaps to first-line treatment in primary care. And the benefit of that is we do get the sample to send off for histology for assessment as well. Some lesions where there is a worry about a skin cancer, we may wish to choose to surgically excise, or there are high-risk patient factors that mean that we're more worried about that lesion. We do sometimes use photodynamic therapy in secondary care, and it's important, whatever you choose to treat your patient with, that you can think about the side effects of the treatment and counsel people appropriately. So if you find that you assess the lesion, you take the history and you're concerned about it, or you're thinking that you might refer to secondary care, it's important to think, if you've got a thick actinic keratosis with an indurated base and it's grown rapidly, it wasn't there 4 weeks ago and now it is, and it's a centimetre in size, you're going to be thinking, oh, is this actually, a skin cancer, or if it's tender, etc. So there are certain things that make you a bit more worried. Anything that's ulcerated that you think is sun damage, it is unusual for it to ulcerate spontaneously it's unusual for it to ulcerate unless you've put some treatment on it already, in which case if you've seen somebody back and they've used Efudix for a couple of weeks and it's then ulcerated, then you might see an ulcerated area of sun damage. But in actual fact, if a lesion is spontaneously ulcerated and it looks like sun damage, then you've got to think, could there be SCC arising within that? And we'd expect to see those patients. The BAD very kindly in their guidance to us sort of highlights what sort of things we need to be thinking about in terms of high-risk patients. So past history of skin cancer, extensive sun damage, immunosuppressed, people with more than 10 actinic keratoses, they're at very high risk a significant risk of getting an SCC, as you say, 10 to 15% over 10 years. So this is cryotherapy. So there's lots of different ways to use cryotherapy. I don't use a single freeze-thaw cycle of 10 seconds, or a single freeze of 10 seconds. But there are, if you're used to using it in your practice, you'll find whatever works for you. But the good thing about it is if somebody presents with a singular lesion, they've not really got much sun damage otherwise, then actually, you can really very much target your treatment just to that lesion and very little in the way of side effects. Can be painful at the time, it's very, very uncomfortable, and there's also risk of blistering and infection. You may leave a scar, but obviously, as we've learnt from asking people in the room, there's only a handful of people that have actually got access to it. So it's not necessarily something that you'd easily have access to in general practice, and therefore probably won't have the expertise in most places. And it's very operator dependent, so you have to get used to using it. So it's difficult if you're only using it once every now and then. So Effudix, I'm sure everyone's heard of Effudix. Effudix 5-fluorouracil, and there are various different treatment regimes. I personally use it once a day for 28 days, having a break if the skin becomes too sore, aiming to get 28 days worth of treatment as close together as possible. And that is what I tell patients. So there are other regimes. I know that some colleagues use it twice a day for 3 weeks. It's generally very effective. And you'll notice that when I was mentioning about the treatment options, it does come up on the treatment options for most AKs. So in fact, all AKs, apart from the ones that you're worried about that you'll be referring into secondary care. So I've put that it's a disadvantage about the inflammatory reactions. It's not really a disadvantage if you appropriately counsel the patient, because in actual fact, it says about being unpredictable. In general, it is not very unpredictable at all, as long as you've counselled the patient. It will make it go red, it will look worse before it looks better, but it will then improve once you've finished the course of treatment. So, and very occasionally you do have to manage potential side effects of treatment. This inflammatory reaction that you get, you can almost predict. So if you see somebody who's got lots and lots and lots of sun damage on their head, and they've never used any topical treatment before for treating sun damage, then the chances are the first time they use it, it's probably going to be the most significant reaction they actually get. So it's worthwhile just warning them of that. You say, well, you have got a lot of sun damage on the background of your scalp, so in fact, you will get quite an inflammatory reaction to this, just to warn you. And most people are able to cope with that when they're counselled. So if you've got somebody with a single lesion and it's particularly thickened, there is this option that I mentioned of Actinic. So that's a combination of 5-FU and salicylic acid for its anti-hyperkeratotic effects, I suppose. The good thing about this is you can literally put it on one lesion. So if you had a grade 2 lesion, perhaps on the dorsal aspect of the hand, then you can put it on that lesion. And it's once a day for up to 12 weeks. Now you can imagine committing to 12 weeks worth of treatment is quite difficult. And also, don't forget, a lot of our patients that are presenting with sun damage, this sun damage is occurring in later life, and they may not be as dexterous to be able to use a sort of nail varnish pot and paint it on. But it is, you can specifically treat that lesion. It's a long treatment course, and I think it's difficult sometimes to ask people to commit to treatment for such a long length of time. So we talked about lesion-directed treatments. So you have the option of Effudix for lesion-directed treatment. You also have the option for field treatment. So if somebody presents with actinic keratoses on the temple, for example, or a cluster of actinic keratoses, you've got the option of treating all of those at the same time with Effudix. So, like I say, I use once daily for 28 days. That's what works for me. You can use it over a pretty big area. So I would treat whole scalp at one time if somebody's got a lot of sun damage. And, again, if you can predict the response to treatment based on the amount of sun damage that people have got in the background and sort of counsel them on that. You put it on at night, wash it off in the morning. It's best to follow patients up if you can at 3 months, or safety net them and say, if it's not gone, then please come back. When people are in the course of their treatment, it will look inflamed, and it can sometimes look quite alarming, but it's an expected response to treatment. And the other thing is that just to be aware of that it is toxic to animals as well. So it's important that people don't let their pets lick their face, etc., because it is toxic to animals. It's just worthwhile letting people know. So again, for small field directed treatment, so this is less than maximum of 25 centimetres, although in secondary care we do use it more than that off licence, of course, in some instances, is Aldara or Imiquimod 5%. Aldara is the licensed treatment. And it's generally very effective. It's 3 times a week for 4 weeks is the regime that's effective, and it does cause quite a lot of inflammation, as you're expecting, just like with Effudix. Just to be aware, I don't know if anybody's come across it, you may well have done in general practice from us advising, for example, treatment of basal cell carcinomas with superficial type with Aldara or Imiquimod, is that actually they sometimes get flu-like symptoms, and that's quite distressing for the patient, and usually we just advise them to stop it. So it's just to be aware of it, because sometimes people can feel a bit rotten. And you don't have to use a full sachet at once. That's the other thing to say. You can use part of a sachet and then fold it over, put it back in the fridge, so that otherwise it ends up with quite a costly treatment. So we looked at some of the data from Greater Manchester and prescribing practices as to what people use, and we know that there's quite a lot of generic diclofenac gel and Solaraze that's used, but the downside to those treatments is what we certainly find in secondary care is they don't tend to be as effective as Effudix, and also they're obviously quite difficult to commit to. So if you're asking somebody to use some treatment for twice a day for 3 months, it's actually quite a long time to keep treating their sun damage. So there is potentially an opportunity to change practice, as we've seen that Effudix is a good option for us, whether we're doing field-directed or field-directed or localized treatment. Obviously, we do see some actinic keratoses in secondary care. Of course we do. We see lots of them. What can we do in secondary care? Well, we can help confirm the diagnosis if you're not sure. And of course, if you're not sure, we would want to see the patients. That's always, where we would stand. If you've given some treatment for actinic keratosis and it's not responded, so we can help with the diagnosis if it's not right, or it might just be that you have got it right. Of course, you probably have, but it's not responding to treatment, and we can decide if additional treatment's needed or surgical management, for example. If you're obviously worried about an SCC, we'd expect those patients to be sent to us from yourselves. If patients have got lots of risk factors, you've got immunosuppressed patients or lots of history of skin cancers previously, then obviously we want to see those patients, and if you're concerned as well. Obviously, if you're worried that a lesion's particularly thickened, then you're going to be sending it in to us anyway, but we might want to treat it with surgical treatment options, and we've got access to things like photodynamic therapy, which I will touch upon, and sometimes we use acitretin to reduce the sort of hyperkeratosis in patients that've got very extensive sun damage, but they would very much be our patients to sort of look after and manage. So just to touch upon PDT, because we mentioned it, PDT is a treatment whereby it can be used for singular lesions or a small number of lesions. It uses a red light which has a certain surface area that you can treat at any one time. And basically what we do is gently curette the hyperkeratosis off the lesions and then put this cream on which gets absorbed preferentially by sun-damaged cells. And then we shine a red light on it and blow some cold air on at the same time because it's very painful, but basically those cells that have taken up the cream then get destroyed by the light as a result of them taking up the cream, and it's really good for lower legs where it gives really good cosmetic results, and your other treatment options are a bit difficult sometimes surgically, certainly in secondary care. So, curettage and cautery, I mentioned it earlier. The benefit that we've got in secondary care is we've got a lesion that's on the borderline of a grade 1 or a grade 2, or it's a grade 2 or a grade 3, and if it's a grade 3 lesion, we're slightly worried it might be an SCC, but we think it's probably not them, and sometimes we'll scrape them off. And the great advantage to us is we then get histology results to see whether there was anything worrisome within it. And we always perform a double cycle just to make sure the lesion is treated. So I was just going to move on to side effects. So we can see in these photos that that these patients are patients that have been using Effudix, and if we look at the photo on the left, we can see that somebody's been directing some treatment to their temple. They've obviously got quite an inflammatory reaction, and they're the type of patients that I might say to them, well, leave it for a few days and then restart, complete the course of your treatment. The person on the right-hand side, they've obviously got a slightly more florid reaction. I might say, oh, well, stop and use a bit of topical steroid, or you're almost at the end of your treatment, that might be enough, like stop your treatment and give you some steroids to help settle things down, or just emollients, for example. So, but, these patients, if you look at the patient on the left-hand side, you'll see that he's got quite a lot of wrinkling. He's obviously a fairer skin type. He's got sort of gingery colouring within his eyebrows. So he's probably somebody who's got a lot of extensive sun damage in the background. So you probably could predict that actually this person's probably going to get a reasonably significant reaction to their treatment. However, we can manage that if we counsel them appropriately. And again, the patient on the other side, on the right, has obviously lost their hair and will have had some sun damage over the lifetime as a result of losing their hair earlier in life. So it's important really to manage patient expectations when you're treating actinic keratoses. They're likely to result in inflammation. The treatment is likely to result in inflammation, whichever treatment you have chosen. The leaflets that you can get from manufacturers, but also on the British Association of Dermatologists website, are really helpful. I don't know if anybody's been on the BAD website recently, but they've now put QR codes on all the leaflets, which is actually really handy, so people can just scan the QR code while they're with you in surgery. You don't have to faff about making sure the printer's working, etc. So it's actually really helpful. And there's one on FUX, there's one on actinic keratoses, but the companies that make these products also have some information about that too. And it's useful to advise people what to do in the event of inflammation. So like I say, use it once a day for 28 days, have a break if the skin becomes too sore, aiming to get 28 days worth of treatment as close together as possible. They know already that they might be having a bit of a break in their treatment, and that's okay. Then, you know, you can say, if you have a particularly severe reaction, then do let us know and we can see you back. And then that way you can always give them some topical steroid, etc. if you want, which we can come on to. And you don't need to routinely, some people will prescribe a topical steroid alongside FUX. You don't need to routinely do that. And certainly I wouldn't do that with my patients. I can't recall having done that at all. But if you've counselled them appropriately, if they did get a significant inflammatory reaction, then that is potentially an option for you to prescribe should the need arise. So if it's a very mild inflammatory reaction, you might just say to the patient, this is an expected consequence of treatment. You should continue using your treatment, your FUX, or whatever else you're using, Aldara. If it's a moderate inflammatory reaction, you might say, take a short break in treatment, consider a topical steroid if you want to. So I'd put Umivate on there. Of course, you can't get Umivate at the moment, or its generic equivalents, but even just a mild steroids like hydrocortisone. If you've got a severe inflammatory reaction, you may wish to stop the treatment and altogether and just say, well, actually, you know, you're 2 weeks into treatment, but you're not going to tolerate another 2 weeks of treatment. Let's just stop and reassess where we're at in a couple of months' time once this inflammatory reaction has settled down. There's a new treatment, tirbanibulin. It is, I think, currently undergoing NICE appraisal. The great thing about it, if it does come to market, would be that it's a short treatment, so it's only once a day for 5 consecutive days. And there's a couple of studies showing pretty good clearance for actinic keratoses, so it's just something to bear in mind that might come along that you might see down the line. And that's just the paper that relates to. Patients will get more lesions with actinic keratoses. It's quite common, actually. So sometimes people say to you, oh, well, they've come back. And you say, well, but how long did they go away for? Well, they went away for 18 months. And it's like, well, actually, it's probably not they've come back. It's probably just that you've got, you know, maybe a bald head and your treatment, you've already had a lot of field damage. We've improved that field damage, got rid of the actinic keratoses. But actually, you don't return those cells to where they had no sun damage. So of course, over time, then they can creep back and you can get more actinic keratoses. So it's not unusual for that to happen. It's important if you do touch base with patients down the line and they're coming back to you either, you know, checking in for other health problems, but mentioning about having treated with FUX, just remember to remind people about using sun protection, etc. Just good health promotion opportunity if you do see patients back in surgery for another reason. So I'm going to hand over to Kate. Are there any questions just at that point in time? Stephanie, go ahead. Do you want a microphone? Fantastic.
So thank you for those of you who've been posting questions online. We just had a couple of questions and comments there, which I'll just share. So from Robert Lamb, we have access to cryotherapy. However, we have found that we cannot provide it under minor surgery ES. Has anyone found this or successfully using with getting payment? It's not sustainable if not funded. Any colleagues, any comments or on that?
I mean, at the practice that I work at in Tameside, I do take the odd referral. Maybe the problem is it's not normally for something like this. It might be for a filiform wart on a face or something. And we are allowed to charge. But, I mean, in theory, as part of your GMS contract, we should all be offering cryotherapy. But as I said to Steph, it's all very well offering it. If you don't know what to do with it and you're potentially going to harm people with it, it's probably better not to be doing it at all.
The next question or comment we had from one of our colleagues online. When I attended the DECIDE training, we were told never to use solar rays since it's costly and lesions often recur. Certainly from my perspective, I can't remember the last time I prescribed solar rays, and I think John, you've already shared some of the evidence. The New England Journal of Medicine paper, which compared Solaraze, Effudix, Imicramod, and PDT, found Effudix to be the most effective treatment, and it is cost effective. And of course, the treatment duration is shorter. And we've shown that we could be saving significant sums of money across Greater Manchester, by modifying our prescribing practices. What do you think, John?
Yeah, no,
Maybe
I would agree. I mean, I'm a bit like you, Stephanie. I can't remember the last time I prescribed it. So I've maybe once or twice in my whole career in dermatology. So it's not something I would use. And with appropriate counselling, Effudix is it's a cost-effective treatment, and also it's very predictable. You can counsel the patient what likely inflammatory reaction they're going to get, and then and you're more likely to be successful using that treatment. And it's easier to commit to for a month rather than for 3 months. So I think there's lots of benefits.
And the last one, whatever happened to Picato? I used to love prescribing that drug. Picato was withdrawn from the market because it led to an increased risk of squamous cell carcinoma. So, no. So I didn't used to like Picato, actually, because I found it quite unpredictable. And in fact, Lisa was just saying the same. But so Picato is been gone for quite a while there. Yeah.
Anything else? Okay, go ahead.
Sorry, if we have access to minor surgery, is there any benefit to us doing a curette and then using one of the topical treatments?
So we do in secondary care sometimes do that. It's difficult. If you've got a lesion that you think that is thick enough to curette, but is not, are you thinking actually could this be an early SCC? So I think it's a bit difficult really. I suppose it depends on your surgical skill, but I would expect those. I'm sure Stephanie would probably agree to send those patients to us. If you're thinking about needing something curetting in primary care, we'd expect to see those in secondary care on the whole.
Yeah, I think the issue there is because we're normally curetting something because we're not entirely sure that it's not a skin cancer there. And then if you're thinking, well, it could be an SCC, then, usually then you want it to come in on the 2-week wait pathway. I think sometimes if you think something does just look like a hyperkeratotic actinic keratosis, there's no induration, it's not tender but really crusted, then what we try and do is get the patients to use treatments to try and descale it themselves, so like emollients, dermol, things like that, try and soften the scales, get the scales off themselves, and you can sort of help show them how to do that in the surgery and then get them started on the topical treatment straight away, because absolutely I agree, if you start putting the cream on, it's already really raised up, you don't get that benefit in the penetration of the treatment.
I'll give you the mic so there's everybody here online as well.
I normally would think AK is a macroscopic clinical diagnosis. Would you say in any particular grades or, you need to do a dermoscope? Because grade 1 in particular, without scaling, it's hard sometimes to associate, is this AK? And what are the particular features you would look for in a dermoscope? Because I
don't put my dermatoscope on actinic keratosis unless I think it's an SCC.
So it's just macroscopic.
So it's quite the AKs are quite difficult. Would you agree with that, Steph? Unless you think something's actually an SCC.
I mean, going back to sort of the teaching Jess was giving earlier, it's the history. It's looking at the patient. They look at a bit sun damaged, and then it's the feel. So it is that full history examination, the feel of it. I think is really clinches it for you.
Yeah. Thank you. The question was, does the pigmentation still stay? Do you mean if it was pigmented in the first place? So it will fade eventually, usually once you've treated it. But don't bear in mind that the patients who have got actinic keratoses often have background pigmentary sun damage. So actually, it's worthwhile, sometimes even photographing somebody's skin before they use their treatment or asking them to do that is helpful, because sometimes patients might say, well, it's not gone, but it's like, well, no, that's just the skin colour in the background that you've got pigmentary sun damage that's always going to stay. But obviously your actinic keratosis is gone or whatever, so it can be helpful.
Steroid creams.
What's the question is, what's the role of steroid creams? So I wouldn't concomitantly prescribe steroid cream if I was using Effidix, for example, at the same time. But if you had somebody with a particularly severe inflammatory reaction to Effidix that was uncomfortable, then I might say, I don't think just emollients, and a pause from treatment or stopping treatment, if appropriate, is the way to go. Then you might suggest in that scenario using a topical steroid. So mild or moderate potency usually. So, unless it was a very severe reaction.
If the treatments, at the end of, say, 3 months, there is still some area of actinic keratosis, how often can we sort of repeat Effidix?
So you could repeat at that point in time. So the question was, if there's still some changes at 3 months, can you repeat treatment? You can. The thing I will say is that patients, when they use the treatment, it's worthwhile advising them that it can stay pink for a little while afterwards. So I tend to say at 3 or 4 months, if it's not gone, go back to your GP or sometimes I'll bring them back if they're a particularly severely sun damaged patient that's under our care, for example, for other reasons. But you just then, if you saw somebody back 6 weeks after using their Effidix, you just say, just wait, yeah. But if they came back and you said, actually, you've had a really good response, but there's just a couple that have still not gone. I'm happy that they're not skin cancers. They're not painful. They're not symptomatic. Have another round of treatment. I think that would be reasonable. Providing you're happy to make that call. Yep. I'll hand over to Kate. I don't think there's any more questions. Nothing else through online. No. Thank you.
Hello, everybody. I'm Kate Outerside. I'm a GP and a GP with extended role in dermatology. So we're going to do some cases, and I'm going to get you all to talk to me. Okay? So the first one is actually not a case, but everything else is. So this is just to kind of remember what we've just heard from John. For an individual with an average of 8 AKs, what's the probability of them developing a SCC in 10 years, in a 10-year period approximately? So everyone have a think. I'll give you a minute or two, and then I'll ask you to just raise your hands for each option if you don't mind. So anyone choosing option A? No? Or one? Option B? Large proportion. Obviously been listening. Option C? Option D? And option E? No. So everyone's been listening. Fantastic. So it is option B, about 10%. Yeah, that's correct. Ooh. So I'm going to just body this out a bit with a bit more information about this patient and ask you to tell me more about what we do for history and things as well. So let's pretend this gentleman in this picture is called Dave, and he's 80, and he's a retired builder. And he was brought in by his wife, Sylvia, and she dragged him into the surgery. He rarely attends, and he's had this on his face for a while. And she said, you need this seeing, and brought him in, and frog marched him into the surgery. When he sits down, what are you going to ask him? So, how long's it been there? Yep. So it's been there about 4 months. It's got bigger. Well, the growing bit's been there for about 4 months, but it was a bit like just had a scaly face for ages. Anything else you want to ask him? Pardon? It's a bit tender. I caught it the other day. It was dead tender there. Yeah, it was, yeah. It doesn't bleed, no. Anything else? Previous skin cancer, good question. No. But I've got a scaly face. I've had a scaly face for a while. Anything else? Sorry. No. He's got a bit of OA, nothing much else. Yeah. He was a builder. He used to smoke a lot. Yeah. Pardon? I can't hear. I'll come to that in a moment, but thank you. I just want more information on the history. So think about the sun exposure risk factors. You've asked a lot about the lesion itself, but let's move away from the lesion and let's think about the patient as a whole. So what else? You know about his job, but what else do you want to ask him? Sorry, I'll need to have one at a time. I can't hear everyone at the same time. Does he use sunscreen? No. Anybody else? Sunburnt in the past? Yeah, he was a builder, so he used to get sunburnt loads. What else? Yeah, good. So yeah. What about his skin? What would you ask him about his skin in the sun? Does anyone want to ask about that? Yeah? So yeah, what I tend to say is, do you tend to burn in the sun, or do you tend to tan, or somewhere in between? And that'll give you an idea. So yeah, that's a good question to ask. That's asking about your Fitzpatrick scale. What about travel and things like that? Yeah, so holidays, you would ask about, have you been on abroad? No. So I'd say, have you ever lived abroad? Have you ever worked outdoors? You know he's worked outdoors. He's never really gone abroad particularly. But if you pin him down, he actually was in the army for 2 years in the distant past. So he did live abroad, but he doesn't think he lived abroad because he was in the army. So it's worth asking, because this is exposure. You know, he was in Egypt for a couple of years. That's really significant to gather. Okay, fine. So I think we've covered most of the history there. What about examining him? We've got a nice little snapshot of the lesion, but what else do we want to look at on examination? Surrounding skin. So in practical terms, I'm a GP. I know it's really hard. We don't have time, but you can get them to take their coat off, lift up here, lift up there, pull their trousers up or take them down and have a quick look. He's high risk. 1, he doesn't come to the surgery very much. 2, he's worked outside his whole life. 3, he'd lived abroad in the army. 4, he's got skin type 1. So he's got loads of risk factors. He's a smoker. So you really should look at the rest of his skin. He doesn't come very often. He's not someone who's going to tell you if he's got a big melanoma on his back. And you could easily find that. Incidentally found melanomas are really common in this age group. So it's worth bearing that in mind. Okay. And I'm just looking at that one photograph. What can you tell about what he's about? So what's his skin type just from looking at that photograph? It's going to be 1 or 2, isn't it? And you can see the background of the actinic damage there on his face, as well as this lesion. I'm sure you've all had a thought already, but what do you think now, coming back to the actual picture itself, what do you think the diagnosis is? SCC, yeah. It's got quite a thickened or indurated base and quite a large keratinized layer, horn there almost. Okay, and so I'm going to ask you now, which one of those 5 options would you go for? E, yeah, that's right. But now you know loads more about him, and you can actually get that really quickly as well. Okay, let's move on, if I can find out how to do it. So this is Jeff. And Jeff has come to see you for his blood pressure check. Jeff is a banker. He's retired, and he has a lot of health anxiety, and he's coming to see you to have his blood pressure checked and his cholesterol looked at, and all those things. He sits down, and you look at his head, and you see this, and you think, oh. While you're here, Jeff, I just want to ask you about your head. So in your tables, I want you to answer those questions there, and I'll come back and ask you to share in a moment. So I'll give you a couple of minutes to just have a look at those 4 questions. Okay? Talk amongst yourselves. Please go. Okay, so I'm going to stop you there, and I'm going to pick on some tables. Is everybody ready to just pause? So the first question, this is Jeff, and he sat down, as I say, and you're going to ask him some history questions. So I'm just going to take this table here and then the one behind. What questions would you ask on history taking?
So we were wondering how long he's been bald for. And,
It's a very personal question. But
I think I'd be all right asking. I'm usually fine asking that
since he
question.
was about 40. Go on.
And whether he's had, does have any extended sun exposure, holidays, does he wear a hat, you know, does...
So
has he been
Jeff
sunburned?
is a banker and he's quite wealthy, and he has a holiday home in Spain where he goes there maybe 2 or 3 times a year. So he loves his
Whether he
holidays.
goes golfing as well or not?
He's a real big golfer,
Yeah.
really big, 2 to 3 times a week, yeah.
Yeah, so lots
Yeah.
of sun exposure from the sounds of it from that.
Mm-hmm. Should we ask the next table what else they'd ask?
We were going to ask him if he'd noticed anything on his scalp himself.
I don't think he had, actually. He hadn't noticed it at all, really. But it's good that you pointed it out. Now he's really worried.
We'll hand over on that question.
Anybody else? Any more history questions? Does he use sunscreen? Sometimes in Spain, he'll use sun cream, but not much elsewhere. No previous history of skin cancer, no skin lesions, no. Non-smoker. Pardon? It's not painful, no, he didn't know it was there. No, but now I'm really worried I might. Anything else? I think you've covered it, but obviously when you think about a skin type as well, so you'd ask the question I said before, do you tend to burn and sun or tan? And then you get a feel, so he's probably type 1 or 2 again. You also need to ask him about sunbeds. Nobody mentioned sunbeds, so that's also a good question to ask, because back in the when he was in his 20s, he'd use sunbeds quite a bit. He was a bit of a poser. So yeah, that's worth knowing. And one of the tables at the back, how are you going to examine him?
Microphone. Well, I'd want to have a look, obviously, at his scalp, assess the level of scale, assess for any other involvement in the surrounding area, but also have a quick head-to-toe examination of him to check for any of the other lesions that we mentioned, and then take it from there.
Yeah, very good. Definitely worth looking at. And obviously you're looking at his background skin type as well, which you're looking at when you examine. Fabulous. So we think this diagnosis is actinic keratosis. So one of the tables sort of in the middle that haven't answered, can you tell me how you'd explain it to Jeff in a way that he can understand what this is? He thinks he's going to die of skin cancer now.
So we can say we don't think it's skin cancer right now. It's related to kind of sun damage and exposure over many years. And there's a potential over several years that it could become a skin cancer, so it's a good idea to keep an eye on it.
So what is it, Doc?
Actinic keratosis.
What's that?
Chronic changes in the skin from sun exposure.
I'm sorry, I'm being a bit mean, but that's fine. So this is chronic sun damage. So it's sun damaged skin, you quite rightly say, that sort of makes the skin thickened and hyperkeratotic and scaly and rough to touch, and it's sun damage. This is not skin cancer, and really emphasise to Jeff that you are a very caring doctor, and you've noticed this because you want to prevent him getting a skin cancer, and you want to treat him and equip him with the knowledge in which he can do that because he's very health conscious. So you're going to help him. You don't want to worry him. This is nothing to be worried about. And you can send along to him this delightful... This is what the BAD actinic keratosis leaflet looks like, and you can ping this to Accurex or whatever way you've got of texting it to the patient, so he can have a lovely read afterwards, and he'll feel very happy about that. So that's fine. And so what are you going to discuss as options for treatment? Somebody in a table over here who's not answered already, preferably.
We're prescribing some Epidix.
Are there any other options?
You could consider solar rays, or you could consider, well, it depends really. If you find just that single lesion, then you want to consider one
He's got, if you look at the top of his head, I think there's a bit of a dry, red, scaly bit there too. Sort of it.
So then if you're considering sort of managing the field, then you might consider possibly some cryotherapy for that one lesion and some Epidix.
But what are my choices? I like to make my own choices. So can you tell me what the pros and cons are of those choices are, please?
No.
Can anybody else?
So obviously with the cryotherapy, it can be painful. You might get a blister. You might need some repeated treatment. With the Effudix, then you might get an inflammatory skin reaction. You might need to use it for a week, 4 weeks at a time, and you may need some further treatment afterwards.
Okay. Is there anything else I need to know about Effudix? Does anyone know? Yeah, it's dog. Watch out for his dog. No, that wasn't what I was going for, but thank you. Go on.
So obviously about the inflammatory skin reaction that you expect, you want to tell them all about that and possibly show them some pictures of what's a normal expected reaction and a plan to manage that if he does get those reactions.
Okay, well done, thank you. So what you
Kate,
can... Sorry.
We have a question online from Professor Minnie Singh.
Oh, thanks, Minnie.
Her chat isn't working, so I'm going to try and unmute her on the computer here if I can, and then share with everyone. Oh, I can't unmute you. I can't unmute you, Minnie, sorry. I don't think the chat's working. Does anyone know, Paul, do you know how we can help Minnie ask her question? Oh, we can't, okay. Okay. Oh, we can do it at the back. Oh, yeah, the IT
Hi.
team
I'll just take another question from the front, if you don't mind. Well, go on.
We did mention about leaving it alone as well.
Yeah.
If there's more than one lesion there, would we not want to treat it?
Not necessarily. What grade do you think they are?
Mild.
Grade 1, maybe 2. So the one at the back is probably 1, the one towards the front is maybe 2. So I think the options I would give him would be, okay, Jeff, we can do different options. We could do no treatment, and we could just watch and wait, and I can teach you about how to look for anything that's changing or evolving to something more sinister. 2, we can give you some nice emollient to rub on. It might soften that bit at the front, make it less rough to touch. It might reverse them, possibly. 3, you can have, you can have Effudix if you want, or you can try, Actinic or some of the other treatment options if you like, and go through, or cryotherapy, and go through the options. But what I would also bear in mind is sort of say, look, I know you like lots of holidays, Jeff. I know you really like to go abroad. Are you going anywhere soon? Because what you don't want to do is say, this is prevention. It doesn't need to be done now. You can delay it. So you would say, okay, well, actually, his wedding of his daughter's coming up in a couple of months. Does he really want to use Effudix right now? Probably not. This is preventative. So you can say, look, I'm not worried. Let me give you the information about Effudix. Let me talk to you about the options. And then after your daughter's wedding, let's get going and treat you then. This is prevention. Okay, there's no rush to treat. Do we have Minnie's questions yet?
Yes, I think we do.
Okay, I think that, thank you, Kate. I think that sums it up. I'm just going to say, if people can hear me, that in my head, when I approach a case, I have 4 categories. And when it comes to treatment management, just like you said, it's 1, 2, 3, or 4. Grade 1, 2, 3, or field change. That's it. What am I looking at? And that determines it. And I completely would like to echo what you said. If it's grade 1 and 2, you don't have to treat it. The conversation is prevention, actually, because there's spontaneous resolution as well. The thing I wanted to emphasize was, though, if this person is immunosuppressed, because we've got to ask that question, so we'll go back into the history, then my threshold changes. I just wanted to highlight that. Thank you, Kate.
Thank you. Thanks, Minnie. Okay, fantastic. So we've covered it. And you're going to send him as well this lovely BAD, referral uracil leaflet, which tells him all about it, about the risk factors. Now, the other thing we didn't mention, we talked about treatment, is the actual cream itself makes you more photosensitive. So they're going to put it on once a day at night for 4 weeks, but tell them that, 1, you want them to use sun cream in the day because you want to protect their skin because they've got sun damage for the future, but also whilst they're using it, and a bit after, they're going to be more likely to sunburn, so they need to use it then too. So you need to just tell them, go and buy some Factor 50. Hi. So if you're going to read this leaflet, which you're going to look online, you apply it to the site you need to treat. Obviously, if you're using field, you applied it across the whole lot, but you apply it to the site and just a bit around, okay? So that's what you're going to tell Jeff. And what you're going to do for follow-up, because, well, what do I know? How do I know it's gone, Doc? What am I thinking about? So you'd say, what? So obviously, it depends when he's going to start the treatment. So he's going to delay it because he's going to his daughter's wedding, so you want to leave it until he's 3 months to say, okay, start it, Jeff, and then 3 months after you finish, come and see me. And you can get him to book it in. He's a patient who can take that ownership because he's a really health conscious man. Somebody else, you might want to put an alert on the system or something because you can't be sure that they're going to do that. And this is fairly mild. Obviously, it's much more extensive. You really maybe want to follow them up because it might not be treatment responsive. It might be evolving into an SC. It might need to be curated by secondary care. So you need to sort of have an idea. Let's move on because I'm using all the time. Oh, we've done that one. Oh, we're going the wrong way. Here we go. So this is Ray. Ray is 80, and Ray's daughter's brought him in. He uses a stick. He's got COPD, heart failure, quite frail, and she thinks he's got a funny rash on his head, and she wonders if it's contagious and wants to know what it is. Just very briefly, because I know we've done it twice already, what do you want to ask Ray and his daughter? I know that I'm asking you to do it again, you've just done it twice, but I really want to get it into people's heads what you're asking. So people who have an answer, tell me what do you want to know, and I'll be Ray. Anyone? No? Duration. So probably been there a couple of years. Pardon? Don't know if it's changed.
Does it bother him?
No, doesn't bother him. And what about his sun exposure history? Sorry? So he used to be a gardener, worked outdoors his whole life. He never used sun cream. He smokes. He's never been abroad, never used sunbeds. He's probably got type 1 skin because he tends to burn quite easily. Never wore a hat. So got a picture. And what's he got on his head? What is that diagnosis? Does anyone know? It is an actinic keratosis, but what type of actinic keratosis? Has he got more than one? So what do we call it when it's more than one? It's a field change. So when it's a field change, how do we think of it differently? How would you discuss the treatment with the patient? Could someone just tell me how they'd explain how we treat a field change, or what options? Yeah. So someone's saying that because he's got more lesions, he's got higher risk. Of course he does. That's absolutely right, completely. But in terms of, let's, for example, say we're going to treat him, we're going to say to him, he wants to use Effidix. How do we explain, how do you use Effidix on a field versus on a single lesion? So you'd pick an area, so you can do the whole scalp, but you'd pick an area and you'd treat that area as a whole rather than the individual lesions dotted. You just treat the whole area for the duration of the treatment, okay? But let's just talk about him specifically. So he is elderly and frail and isn't really bothered about these. What are our options? What else could we do? PDT, well, you could. Anything more that we could do lesser, perhaps? Pardon? Emollients, yeah. So one option is actually to do nothing, but watch and wait. So I think that might be a suitable option for him. He's elderly. He's not bothered about them. He can't be bothered with the faffing around with the Effidix and the inflammation. His daughter's there for him. She's looking at his head every day. They don't want the hassle of it, and they say, oh, just give me the cream. I'll just moisturize it and see how it goes, and I'll buy him a hat. And that's what she wants to do. That's reasonable. But to support yourself with that, please send them the information about actinic keratosis. Please also send them, for the daughter to read some information about how to protect their skin in the sun. The PCDS has got a useful leaflet. I'll pass these around at the end. And also for self-management, this is the PCDS sort of what to look out for skin cancer, so you can pass around to them as well. They might be quite happy. The daughter's sensible. She's caring for him very nicely to sort of look at his skin and check it regularly every couple of months and see anything new or changing. You say, okay, look, if something's rapidly growing, painful, ulcerated, then please come back. And they might be happy with that, and that's entirely reasonable. Some of these might reverse anyway because some of them are grade 1 or and that's very reasonable to do, but make sure you safety net them fully and document you have as well. And that would be reasonable in this case. Otherwise, as you say, use the field treatment. If he wants treatment, Effidix is a good choice, and do field treatment, and then I'd get him to review after 3 months because some of these within that might not respond, and they might need either a second treatment or further referral for surgical intervention. Okay. And what about this one? So this is Marie. She's 60 and she's used Effudix for 28 days and she has this appearance. What do you want to do? I can't really hear what people are saying, sorry. Sorry, is there a microphone or can someone speak up? I'm so sorry.
If she has come back right after 28 days, I'd probably say moisturise, sun protect, come back at 3 months.
Yeah.
But if this is at 3 months, then I might want to try another cycle of Effudix, or has she used it effectively?
She says this is really painful and like it's a bit yellow now. I'm a bit worried about it. What shall I do now?
Probably refer, but I'd also think whether there's any secondary infection, etc.
Yeah.
If it's crusted.
So those, do they look a bit yellow, those crusts? Yeah, what does that make you think of?
Staph infection.
Yes. So you need to look at the context. So clearly this is used Effudix and it's done the inflammatory response, which you want it to do. And they've got this kind of crusty areas that are yellow, and that looks a bit like staphylococcal infected. And so you might want to say, let's just use a little bit of topical steroid, maybe some Fusidin, H or something like that might be reasonable to calm that inflammatory response down. So yes, you want to see them at 3 months, but if they're having a response that's quite severe during the course of their treatment, you may also want to treat them during that time for an infection or with a small amount of steroid or emollient, that kind of thing, just to settle the response down. But they've obviously had a good response. They've got a good chance that their AKs will resolve once they've kind of finished. If they're midway, they're 28 days now, so they're at the end of treatment, but if they were midway through their treatment, you might just say, this is the time to pause and take that break and get things to settle down a little bit with those treatments I've suggested, and then go back on and finish 28 days. Okay. And this is the last case, I think. Yeah. So this patient is 64-year-old called June, and she is a renal transplant patient, and she's got this on her cheek. What are you going to do with her? What are you going to ask her? What are you going to look at? So what risk factors do we immediately know she's got? One, she's immunosuppressed, she's a transplant patient. So you want to know the other red flag risk factors you want to know is her previous skin cancer. So she's previously had an SCC 5 years ago. And did she have high sun exposure history? So she used sunbeds in the past. So she's got 3 reasons that you are thinking this is a high-risk patient. So what do we think this is on her face? Does anyone have any thoughts? You don't have to formally what are your diagnostic differentials?
We have someone online saying possible SCC.
Yeah, it is. Any other thoughts? Yeah, that is a good point. It could be traumatic. Absolutely. So you do need your history even in these situations, of course, because you don't know whether she's fallen over and banged her face, but presumably she hasn't, and she's had this for a while and it's been growing. But another differential, because it's got a lot of telangiectasia, maybe it's a BCC that's just really ulcerated. We don't know, but it's clearly something sinister. It needs a secondary care input. It needs a 2-week wait. Don't pass go, refer. But explain to the patient and educate them and those sort of things. Okay. So I think that's my last case. Does anyone have any questions? How confident are you now, having done all that and all that chat, in diagnosing an AK? Has it improved? I hope it has. Got some nods, fantastic. How confident you are to discuss your patient treatment options, pros and cons? Yeah, and how confident are you to recognise and management treatment-related side effects? More confident, good. And we've talked about the resources. I'll pass these around. I've been flashing these around, but I'll pass them around so you can have actually proper look at them if you've not seen them, so you can cast your eyes through what you're possibly going to send patients out. It's really easy just to find them online and send a copy of the email link onto people's text messaging through Accurex or whatever system you use, and you can just ping them out, and it's really quick and easy, and they'll get that information straight away. That's it. Fabulous. Thank you, everybody.
Kate, can I just highlight as well, as you were mentioning earlier about seeing patients back after treatment, and it's something that I've done myself earlier in my career, and I encourage our registrars to do as well. So although in secondary care now I won't routinely follow up patients that say treated with Effudix for AKs, I think it is really useful and helpful to complete that cycle, as Jess was talking about, that reflection, that process of learning, to give you more confidence and help you get familiar with the treatment, to see patients back after you've treated them and talk to them about their experience of using the treatment as part of the learning process. So I think that's a really helpful point.
I don't follow them up in secondary care, but I always follow up in primary care because it's something a bit different. They're not used to it. Just also to give the patient confidence that it's gone. And they may not attend. You just say, come back and see me. And usually just the ones that it hasn't gone will come back. But it's nice for the patient to know, because it is quite dramatic treatment they're going to go through, to know that you want to see them again. So I sort of offer that. And obviously, if they're high risk, you're more likely to sort of want to see them yourself and put that in place so that it'll happen through the various recall systems. Okay, fabulous. Thank you.
So the next part of the meeting is the panel discussion. So John, Lisa, Kate and I can have a seat on the front and then maybe answer any questions and also share some of the things that we're doing in Greater Manchester to try and support you guys in lesion recognition and dermatology in general. So first of all, does anybody have any questions on the things that we've covered so far this afternoon from the floor? Or even online?
So in the practice, we've seen a couple of letters come back from dermatologists recently, so secondary care, with the advice for Effudix to be once a day, Monday to Friday, then take Saturdays and Sundays off and do that for 4 weeks. Is that something that you would encourage?
I think everyone has their own Effudix regime, because even the BAD guidelines slightly different to what I do. I mean, I do daily for a month, having a break if the skin becomes too sore or inflamed, and completing the treatment if you can. And that's just sort of the way I explain, very similar to John. Lisa, how do you do it?
No, it's fun, isn't it? You get completely used to your old regime, and I think at Tameside the consultants used to say 6 weeks. And also, if it's not inflamed, it's not working. So if you're just using it once a day, you might need to use it twice a day, because you actually do want to get a bit of an inflammatory response. I'm loving the idea of not doing the steroid thing, because I think classically we've given out lots of tubes of Umivate that are probably sitting at the bottom of people's bathroom cabinets. But the regime you're mentioning is actually the one that I've normally seen used with imiquimod or Aldara, and I just wonder if there was a bit of confusion there, because that classically I would tend to use for weekdays and have a holiday over the weekend for 4 or 5 weeks.
Yeah. No, I agree, because the Monday to Friday is classically Aldara for superficial BCC that we do as a 6-week course even. And I would say that not everybody has a huge inflammatory response. My dad used it on his bald scalp and he had hardly any inflammation, but it worked, just went slightly red. So, but you normally expect to see something. Kate, what's your Effudix regime?
I think it depends. Sometimes I use it twice a day for 3 weeks. Sometimes I use it once a day for 4 weeks.
How do you make that decision?
I think twice a day for 3 weeks in more younger and motivated patients who are maybe older, maybe once a day for a month, are more likely to use. But also, perhaps if they've got a lot of lesions, maybe once a day is a bit kinder, because I know they're going to get perhaps quite a lot of inflammatory response. So you can give it a twice a day to people who've got 1 or 2 lesions, just to get it over quicker.
Just adding on to that, can these patients who are on twice-a-day regime apply sunscreen straight after using the Effudix?
So it's best to put the treatment on at night, and then obviously not wash it, have a shower in the morning, and then they can put their sunscreen on. The other thing is that some people might not tolerate putting anything on their scalp when it's really inflamed, so putting a hat on is the best thing to do in that scenario. So with a broad brim, ideally, or not go out in the sunshine. So, but like Kate was highlighting earlier, it's really important to defer it. If you're in the height of if it's August and it's 30 odd degrees outside, you might say, well, actually, there's no urgency in treating this field change. It's just to try and make your scalp feel better and less rough, etc. Then delay it till the start of October or a bit later in the year. It's fine to do that as long as you're not worried about a lesion, which of course you'd be sending to us anyway in secondary care. So.
And second question is Effidix equally toxic to cats and dogs?
Yes.
Okay.
Well, there is a case report of a very distressed patient that turned up into a dermatology department, their dog having eaten the contents of a tube. But I mean, you've got to bear in mind that lots of people let their pets lick them. So if they're using it on their hands or their face and that sort of thing, then it's just worthwhile letting people know about it. And, and children, of course. I mean, you're not supposed to ingest it. So, it is 5-fluorouracil. So, yeah. Anyone else? Any other questions?
Sorry. You obviously talked about the area that you treat, but how much of the cream? Is it kind of similar to steroids where you have to be kind of careful about the volume, or are we telling them just put it everywhere and it's fine how much you use?
I think it comes in a 40-gram tube, is it 30 or 40? So yeah, so it's a reasonable sized tube. So you've got to. If you're thinking somebody's treating the top of their scalp, I'd probably say to them just a bit like the fingertip units, use that amount. If they're treating an individual lesion, it's just the area and enough to cover half a centimetre around it, really. So, but it's rare that it's quite uncommon to actually just treat one lesion. Often you'll find there is just a few little AKs on the temple, so you might get them to treat the whole area, for example. So, but yeah, I think as long as you're not saying put a whole tube on, because of course that's far too much. But yeah, in fact, Steph, do you want to maybe just?
Just another bit of a tip, really, as well. Quite often we'll see ladies with actinically damaged chests, and they've got quite a lot of actinic keratoses on a background of pigment change and general features of skin aging. And if they're keen for treatment and you're going to treat them with Effidix, then you have to be particularly careful, in my experience, in this area, because it highlights up and they have a very inflammatory reaction. And I have seen patients, and it's like a chemical peel, and then they're left with very pale, fresh skin, which is very nice, but doesn't at all match the rest of their surrounding skin, and that can be distressing, obviously, for the patient. So it is important. I counsel particularly about that, of the risk of permanent post-inflammatory change, which does then not match the surrounding skin. So I do tell patients to be a bit more careful in that setting as well, so that if to pare it back if they are getting quite a lot of inflammation, to prevent that from happening. Because of course that doesn't happen overnight. That's a cumulative effect when people have been using the Effidix and then getting inflammation, then carrying on with it. So just something to be a bit aware of there.
The other thing is to remind people of the importance of stopping the treatment. So even if they don't get much of an inflammatory response, occasionally I'll get somebody coming back to secondary care and say, well, I've used it every day since you saw me last. That was 4 months ago. No wonder it still looks like this. So it's just really important to say, stop treatment if you haven't had much of an inflammatory reaction. Like Lisa was saying, you can go up to twice a day if you want to, but don't do longer than the sort of original prescribed sort of treatment period, because occasionally you get people who come back and they have complications as a result of daily application for a long time. So I think there's another kind of question.
When would you use diclofenac?
When would you use diclofenac?
I wouldn't. I never do. I don't think it's very good. I think it's more expensive than Effidix now and less effective and harder to manage. So I would just park it personally. But yes, I was just going to say, with the leg, obviously the leg's skin heals less well. So I have seen the odd patient who use Effidix that can get an ulcer in the leg, particularly if they've got sort of older skin or they're sort of more elderly. So just counsel patients on that too, to kind of come if they get a really inflammatory reaction, because it will take longer to heal, and the 3 months might not be long enough for that inflammatory reaction to resolve. So sometimes they can still be quite inflamed and red after the course of treatment. So just because it still looks red doesn't mean it's still ongoing okay. It just might be you need to give it maybe another couple of months before you look at it again before it then fully heals.
Just regarding treating field change with Effudix, could you just recap what the largest area is you can treat in one go?
I think it's 23 by 23 centimetres on the in the BNF, so it's quite a large area. I would tend to say, so if you've got a patient, the backs of their hat, really covered, then I would tend to say cycle it round the affected area. So, do the forehead and scalp 1 month, do the backs of your hands the second month, just break it down a little bit like that, just so it's not too much for them. Are you the same, Lisa?
No, very much so, yeah. And actually, I will almost say, because it will be sore and irritable, just choose just that bit of your scalp to begin with, and then do that bit, so that give them some ownership over it, but explain that total length of time for each area. And I always very much go with the whole, but you've got photographs coming up over Christmas or whatever, that whole deal about it not being urgent, I think is really important.
Yeah.
Emollient-wise, would you prefer, what kind of emollients would you say we should offer them? Cream-based, ointment-based, just an idea of what kind of works best for patients with actinic keratosis?
In all honesty, it doesn't really matter. We've got really strict guidance on the cheap stuff that we're meant to use, like Aproderm and things, which tends to be very well tolerated. Personally, I love Dermol because you can use it as a soap substitute as well. It's a pleasant emollient, and you've got that benefit of preventing secondary infection. So when you think they are at higher risk because of picking or because of the inflammation, Dermol can be very effective.
If they've got a very thick keratin layer, though, you might want to use something ointment-based, so something greasy, because that will soften that. And you can, in clinic, sometimes we do that. So someone comes in with a really thick keratotic area, we'll get like a tube of thick emollient and stick it on, and then get one of our staff to peel that off, so then we can see what's underneath it, because that's what we care about, to see whether we're worried about it. So you can, maybe not that brutally, but you can give patients that treatment to try and get rid of their scale before they then use their Effudix, and that can be useful when they're really thick.
Hi, I've got one question about scaling and on the scalp. I have prescribed some patients things like Capsol or therapeutic shampoo for descaling. Is that something that you would advise for patients with lots of scaling on the scalp, from actinic keratosis before starting something like Effudix?
No, I would just use an emollient, to be honest. I think, obviously, people can get scale on scalp for many other reasons, and things like Capsol can be good for people with psoriasis or a very itchy, peely scalp, but not particularly for AK.
The thing about scalp, if you think how long shampoo stays on your skin, it's actually not very long. One of the great benefits, really, for those types of treatments is often for washing out, like greasy treatments on the scalp, actually. So I find them more helpful for that, and possibly helping a bit with itch. But they're not going to get rid of your thick hyperkeratotic areas. These are abnormal dysplastic cells that are not cancerous, but they're not forming a normal cornified layer on the top of the skin. They're causing this hyperkeratosis. So actually, you're emoliating that skin and allowing those thickened areas to soften and then come off in the shower with a flannel or whatever is much more helpful than trying to sort of descale with a short contact, shampoo or whatever like that.
Actually, I just suddenly had a thought about what I like thinking when I'm teaching about AKs as well, is this feel thing. So when you're talking about scale, so the Seb-K type scales that pick off, or it can soften. Whereas the thing with AKs is they feel like fingernail. When you pick them, they've actually got that hard, flicky kind of hardness of the keratosis, which I think does tend to be distinguishing. So when we're talking about feeling them, it is that really hardness, and they kind of don't pick off. If they pick off, they bleed. They're in the skin rather than on the skin, which I think is quite an important definition.
I don't prescribe it, but for field change, we say the size of a palm normally, and you did say you can go for one half and then you can go for the other half. But people who aren't as compliant, or you think they wouldn't do it, is there a role for diclofenac gel or imiquimod? Because I think those two are the ones that I think were recommended in PCDS, like for large field areas. I've read somewhere, but I haven't used it. But
I mean, I think, you know, with the size of field that you can use with FUDIX, I don't think there's a problem, you know, the amount of area that you can apply FUDIX to. I'll tend to use imiquimod more to treat superficial BCCs because the evidence is that it's superior treatment for managing BCC. But when you look at the evidence, FUDIX is the most effective treatment. So that's why we all use it. And you know, when we're thinking of sort of cost effectiveness, obviously all of us are thinking of that all the time. Then, you know, and there's evidence to support it. I don't see a reason not to use it really.
I think the point is Solaraze is diclofenac. It is an anti-inflammatory. So it might reduce the redness and irritation of them, but it doesn't reverse the damage. Whereas FUDIX actually does bring around healing and improvement in the actual architecture and nature of the skin, which Solaraze doesn't do. So if you're wanting to actually treat the problem, you need to use this chemotherapy in a tube, whereas Solaraze is just stuff that you'd otherwise rub on something that was inflamed.
Yeah, no, I've got nothing against FUDIX. I mean, I've never tried anything other than FUDIX, but this was somewhere I read for larger field areas. Maybe these two are preferred, but I guess today's take-home message is just stick to FUDIX. Whatever, yeah, thank you.
One more thing. So you've treated it with FUDIX, 28 days. You've seen them after 3 months, and the lesions are still there. What would you do then?
So you can repeat treatment if you want to. If you are in primary care and you know you're worried, then you can refer in for us to discuss alternative options, such as you know, and the patient is keen for treatment. This is photodynamic therapy, for example, or if there's just a couple of individual lesions, is cryotherapy an option? Is that something you can do locally? Is it something you need our support with? So it would depend on the individual circumstances, but I think you've got a number of options available to you in that circumstance, which are either discussing with the patient, monitoring if that's what they prefer, cryotherapy, alternative topicals, repeating the FUDIX, something such as imiquimod. Yeah.
And there's also advice and guidance, of course. If you feel like if you've got the access to advice and guidance from your local dermatology service, you might want to, phone a friend in that scenario as well. And they might, if you're happy then to action the advice that you get, then that would be fine, of course.
Good morning. I had a letter back from a renal doctor recently, with their transplant patient, who asked me to see some skin lesions because a dermatologist that was attached to that service is now not provided anymore.
Right.
Which was a surprise. And
okay.
It was Salford. And the only reason I asked that triggered this memory was because you mentioned in your piece that it would normally be dealt with by a dermatologist. It seems sensible that the high levels of SCCs and cancers are seen in those patient cohorts.
Yes.
And it's a bit risky to then ask, I mean, we can pick these things up and we would utilise 2-week referral, but is that something that's been done?
So that situation is likely to change. The dermatology transplant clinic has paused in a way, I suppose, but it is going to come back in the near future. But you should be writing back to say this patient needs to be under the care of a dermatologist, and that's totally reasonable.
I absolutely did.
Yeah.
So,
yeah. I'm glad it wasn't Dr. Newman. I don't know who that is, by the way. It's not me.
Send all your referrals to Dr. Newman, yeah. And it's nice guidance that patients who've had a transplant should be having an annual skin check. So ideally that is recommended to be in a dedicated skin transplant clinic, but actually it is up to the decision as well of the patient and the local treating service if they prefer to be seen locally. So I'll see some transplant patients at Stockport, for example, for their annual reviews because they prefer that rather than travelling to a dedicated clinic, and that's perfectly acceptable for patient choice, but they should be under secondary care. You're absolutely right.
Having said that, which is absolutely right, of course, the patients who are transplant patients are still your patient, and if they come with something new that's rapidly changing, then still 2-week wait them, because the year is too far off for them to wait. So obviously you know that, but just bear it in mind.
So I just wanted to take this opportunity as well to highlight, as Jess already mentioned at the end of her talk, the face-to-face follow-on sessions that we'll be having. So this is going to be, for any of you that are familiar, the DECIDE model type of training, where we're going to have small group teachings with patients to look at some of the things that we've been talking about, and having our follow-on talk, Lisa and I are going to talk on some of the skin lesions and the use of the dermatoscope. So we'll be having some bedside teaching, as it were, with patients to show some real-life examples of these sorts of things as well. So hopefully to cement the knowledge, I think really helpful. We'll be sharing that information with you as well. And I think the one other thing that we wanted to mention in this session is that so Greater Manchester Dermatology, working closely with us in the Skin Cancer Pathway Board, are looking at a lot of different ways to try and improve dermatology services across Greater Manchester. And one of the things that we're working on is an interactive referral consultation template, which will be coming online to you guys in primary care to help support managing and making diagnoses in primary care, so that as you make a referral, things will be flagging up, source of information, links to things that will be helpful, sorts of things that we've covered today, for example. And we're hoping that this will be a really helpful thing. So we've got colleagues from across Greater Manchester, so primary care colleagues working on this, some of us from secondary care as well, and also commissioning groups. Paul, is there anything you wanted to add on that? Paul is one of our team who's been heavily involved in this from the go, so he might be able to explain it a little more eloquently. But again, if anyone's got any feedback or ideas on that, please do feed in.
Thank you. So it will link to the clinical decision support tool that the Council Alliance have made available to general practice. The development work's going to happen kind of now, leading up to the end of the calendar year, and there'll be some pilot sites in January. But it will follow the similar process as Think Cancer, where it'll be a number of prompts and it will guide you through a particular algorithm. So we watch this space and we will consult on it, and there will be a pilot for it as well.
Great, thank you, thanks. So I think if there's no more... Oh, Kate's got something.
I just wanted to make a plug. So, if that's okay. So myself and two other dermatology consultants, Dr. Jen Sharif and Dr. Emma McMullen, have set something up which you may know about called the Greater Manchester Skin Club. I just wanted to open the invite to anyone if they're not aware of it. So this is a once monthly interactive remote teaching session on dermatology, not just skin cancers, but anything across the board in dermatology, run by us three. And we will invite in other speakers at other times. This is specifically for GPs and any allied healthcare professionals or trainees working in primary care that just want to upskill a little bit on different areas of dermatology. We try to make it as interactive as possible and have case examples. And if anyone doesn't already know about it or would like to be invited to any of these meetings, they're usually about the third Wednesday of each month. It's 12:45 till 1:30 usually. So hopefully it's a reasonably convenient time. But if anyone's interested, I'll leave a piece of paper probably there, and people can just pop their email on, and I'll add you to the email list when it's sent round for invites. I think the next one is 2 weeks' time or something like that. Okay.
So I think, is it time for a coffee break? Is that right? Yeah. Lovely.